It's a pleasure to introduce Dr. Shruti Gupta, who's our director of onconephrology at the Brigham and has had made tremendous contributions in the field of the immune AKI related to immune checkpoint inhibitors, which is the topic of her talk today. Go ahead, Shruti.
Thank you so much, Dr. Mount. I am very pleased to talk about a subject that's very near and dear to my heart, which is acute kidney injury related to immune checkpoint inhibitors. Here are my disclosures, none of which are relevant to this talk. And the objectives of the talk today is to first explain some of the key risk factors and clinical features of immune checkpoint inhibitor associated acute kidney injury, which I'll refer to as ICI-AKI. And next to describe some of the complexities associated with diagnosing and treating ICI-AKI. So first, we will start with a representative case. It's actually a patient that I saw in my own onconephrology clinic. This was a 63-year-old female with metastatic lung adenocarcinoma, and she was on treatment with pembrolizumab and pemetrexed maintenance therapy. And she was coming to see me for evaluation and management of AKI. She was previously on what we call triplet therapy with carboplatin, pemetrexed, and pembrolizumab. So 3 potentially nephrotoxic agents. And then she was transitioned to the pemetrexed pembrolizumab maintenance regimen. And her serum creatinine rose from a pre-ICI baseline of 0.7 to 1.4. Her urinalysis was completely bland. She did report some previous non-steroidal anti-inflammatory drug use. She had no other immune-related adverse events, meaning no other sort of evidence of inflammation in other organs while on immunotherapy. And she also had a history of proton pump inhibitor use. And so the question is, what is the next step in her management? And we'll come back to her case momentarily. But first, this is just 2 graphs that highlight how immune checkpoint inhibitors have really exploded on the scene. And you can see that even just within our own institutions here, we have nearly 4,000 patients who are newly initiated on these drugs each year. And that number continues to grow. There's now over 20 different indications for ICIs. Now, in terms of the mechanism of action of ICIs, so these basically block immune inhibitory checkpoints and they release the brakes on the immune system, which therefore allows these cytotoxic T cells to go forth and kill the tumor cells. They do this by releasing a number of cytotoxic molecules like TNF alpha, granzyme B, interferon gamma. The problem is that a number of other organs, including the kidneys, can become essentially an innocent bystander in this process. And you can see the whole list of itises or inflammation in all the different organs that can occur in the setting of ICI use. And these are the immune-related adverse events, or the IRAEs, that patients can develop. And this entity of ICI-AKI was first described actually by some of our own physicians here at Mass General Brigham, as well as some physicians at Yale, where they describe some of the key sort of histologic patterns on kidney biopsy of patients treated with ICIs who developed AKI. And basically what they showed in these initial case series was that most patients had acute tubulointerstitial nephritis on kidney biopsy. Now, one of the key questions that also came up early on was, we know that acute kidney injury is common in patients with cancer in general, but how much of it is truly attributable to the ICI? And this was a nice study led by some colleagues at Mass General, where they showed that 15% of patients will have kidney injury at some point during treatment with ICIs. But 8% will have sustained AKI, and only about 3% will have ICI-AKI, where the AKI is directly attributed to the ICI. Now, we now know that that's probably a bit of an underestimate, and we're seeing more and more patients with almost subclinical ICI-AKI. And so this number is probably higher than previously reported. Now, in 2021, we decided that we wanted to kind of move beyond just case series and actually look at, in a more rigorous fashion, some of the risk factors and clinical features and outcomes of ICI-AKI. And so we conducted this grassroots multi-center international study This was with Dr. David Leaf here, one of my collaborators and mentors here at the Brigham. We looked at 429 patients with ICI AKI across 30 sites in 10 countries. And we collected a lot of granular data. It took our collaborators nearly an hour per patient to enter the data. And we collected detailed data on these 429 patients diagnosed with ICI AKI and collected information on demographics and comorbidities, concomitant treatments with other nephrotoxic agents, prior or concomitant extrarenal immune related adverse events, laboratory and biopsy data, and treatments for ICI AKI. We also looked at outcomes longer term, like renal recovery, rechallenge after ICI AKI, as well as survival. Now, this was how we defined ICI AKI, and we either defined it as a more severe rise in the serum creatinine from baseline or a lesser increase, but patients had to have sort of clinical evidence of ICI AKI, either by histopathology, or they had to have been treated with steroids or had their ICI held due to concern for ICI AKI. So we did not require a kidney biopsy for sort of entry into the study because we know that in practice, a lot of patients are not diagnosed that way. And so, in terms of what we learned, we found that the timing of ICI AKI is highly variable and it can develop at a median of 16 weeks after ICI initiation, but some patients might develop it after a single dose and others nearly a year following initiation. And so, the timing of onset doesn't really help you when making the diagnosis of whether it's from the ICI or not. We also looked at the severity of AKI, and we found that 18% had stage 1, 34% had stage 2, and nearly half had stage 3 AKI. Although there may have been some selection bias whereby, our collaborators selected the more severe cases for input in this study. We looked at the incidence of extrarenal IRAEs, and we found that 57% of patients had another immune related adverse event. So they had evidence of inflammation in these other organs. And the more common organs were rash and colitis, as well as thyroiditis, which is quite common in these patients. Now, one of the other sort of really important takeaways from our study is, could we actually diagnose ICI AKI based on clinical or laboratory features? And the answer was no. So, we might think that things like pyuria or proteinuria or eosinophilia are sensitive or specific for the diagnosis of interstitial nephritis from the ICI, but we found, in fact, that none of these features were sensitive or specific. We looked also again at the pathologies on biopsy, and what we found was sort of supportive of what we had seen with some of these initial case series, which was that over 80% of the biopsied patients did in fact have acute tubular interstitial nephritis. We also looked at risk factors for ICI AKI, and the risk factor that was borne out to be one of the strongest risk factors was PPI use. And this was then subsequently borne out by other studies as well. Now, the mechanism for whereby PPIs may actually promote ICI AKI is still not clear, but the thought is that PPIs lead to activation of these drug-specific effector T cells that then become latent over time. Then a patient starts an ICI, and that leads to reactivation of these drug-specific T cells, loss of tolerance, and ICI AKI. And so this is one of the main reasons why whenever I'm treating a patient with suspected ICI AKI, I always try to discontinue the PPI if possible. We also looked at treatment, and the majority of the patients in our study were treated with corticosteroids. And in fact, 100 of the patients even received IV pulse dose steroids, but we did not find that treatment with pulse dose steroids was associated with a higher incidence of kidney recovery. Now, speaking of kidney recovery and also rechallenge, so we looked at renal recovery in our cohort and found that 64% of patients did have kidney recovery with treatment with steroids. And when we did a sensitivity analysis limited to the patients who were treated with steroids, we found that early treatment within the first 3 days of diagnosis was associated with a higher odds of kidney recovery. And so that's really important. And so when you have a patient with more AKI and you really think it's from the ICI, you don't want to dilly-dally and wait to try to make the diagnosis and say, oh, maybe it'll get better. You either want to go ahead and biopsy or treat empirically with steroids if a biopsy is contraindicated. We also looked at rechallenge following ICI AKI. And interestingly, we found that of the 121 patients who were rechallenged, only about 16.5%, so fewer than 1 in 5 patients had recurrent ICI AKI after rechallenge. And so what that tells us is that the majority of patients can probably be safely rechallenged. So coming back to our case, and just as a reminder, this was a patient with a bland urinalysis, and she had no other immune adverse events, and she had this history of proton pump inhibitor use. And so, the question again was, what is the next step? And as a reminder, the urinalysis being negative, this is neither a sensitive nor specific feature for ICI AKI. The fact that she was on a proton pump inhibitor may have suggested that she could have ICI nephritis, but she did not have any other immune-related adverse events. And so this is a case of a patient I'd probably want to pursue a kidney biopsy because the diagnosis is really unclear. And this is always sort of the perennial question, William Shakespeare said, to biopsy or to not biopsy. That is the question. And this is precisely the conundrum that we face when we are taking care of patients like this one. And we know that it's often not so clear cut who should or should not get biopsied. This patient I highlighted here was in fact receiving combination therapy with a number of other drugs that might be nephrotoxic, like pemetrexed and platin therapies. They can both cause acute tubular injury, which would be managed very differently from interstitial nephritis. And so this would be the type of patient that we'd want to biopsy. And we also often take care of patients with renal cell carcinoma who have a history of a solitary kidney after nephrectomy, and they're on therapeutic anticoagulation that can't be safely stopped. So those are the patients that we may not necessarily pursue a biopsy, and we may opt to treat empirically with steroids. Now, of course, what we really need and what we have been working towards for many years are non-invasive biomarkers of interstitial nephritis in these patients. And so this is actually what we did recently. We teamed up with some collaborators like Dr. Megan Seiss at MGH, Dr. Dennis Molodina at Yale, and we actually pooled blood and urine samples from patients with biopsy-proven interstitial nephritis from the ICI, as well as patients who were treated with ICIs but developed kidney injury from other cause, as well as patients who were treated with other anti-cancer agents and developed AKI. And we basically conducted urine proteomics, where we did an unbiased approach and looked at 147 unique proteins in the urine of these patients. And we found that urinary CXCL9 was predominantly expressed in the urine of the patients with interstitial nephritis. And we then confirmed these findings using immunoassay. And so I think this is one step, towards us finding some better biomarkers that can help us non-invasively distinguish ICI AKI from non-ICI AKI. Now, there's also other potential biomarkers that might be useful, and in particular, radiographic biomarkers, I think, are underutilized. We know patients with cancer often get PET imaging, and they do it for staging and for detection of other toxicities and treatment-related complications. And so we actually went back and we looked at the PET imaging of patients who were treated with ICIs and developed kidney injury. And we basically looked at patients that had a baseline PET scan prior to starting therapy and patients who happened to have a follow-up PET scan around the time that they developed kidney injury. And we looked at the change in the SUV mean. So basically that's a measure of radiotracer uptake from that baseline PET scan to the PET scan at the time of AKI. And we found that in the patients with ICI AKI, the SUV mean increased by 57% from that baseline to the follow-up PET scan, whereas it only increased by 8.5% in the patients that had AKI from other causes, and it decreased in the controls that didn't have AKI. And these three patients highlighted at the top in the squares, those were the biopsy-proven patients. So they had the greatest increase in their SUV mean from baseline to that follow-up PET scan. And when we looked at the area under the curve for this change in SUV mean for differentiating ICI AKI from non-ICI AKI, it was 0.97, which was really high. And it was unchanged even when we conducted a sensitivity analysis where we excluded any patients in the control group if they happen to be getting other interstitial nephritis causing meds like PPIs or NSAIDs or antibiotics. And this is actually a representative image of a patient with a baseline scan and a follow-up PET scan at the time of AKI. And you can see how nicely the kidneys are lighting up in the patient with ICI AKI on that follow-up scan. All right, so I know you're dying to know what happened to our patient. So for our 63-year-old woman who was on this regimen of pembrolizumab and pemetrexed and had the bland UA and no other immune-related adverse events, we actually did decide to pursue a kidney biopsy because it was really important for sort of helping to guide the oncologist about which of the three therapies she was receiving might be causing the kidney injury. And we found that, in fact, she had raging interstitial nephritis. She had, you can see here, the sea of lymphocytes on her biopsy with occasional eosinophils. And so with that, we started her on prednisone, 1 mg per kg, while we were awaiting the biopsy, because again, as per our study, we found that early treatment is really important and we didn't want to wait necessarily for the biopsy to come back. And she did, in fact, have some improvement of her kidney function, not quite back to baseline. We did counsel her oncologist that she could be rechallenged with the immune checkpoint inhibitor, but this time off the proton pump inhibitor, and she did well without recurrence of her ICI AKI. Now, we know that sort of the mainstay of treatment, at least for now, for ICI AKI is corticosteroids. And, one of the other questions that always comes up is, well, how long is long enough and how long is too long? And, we are about to embark on a clinical trial looking at other agents for ICI nephritis, but traditionally patients are treated with pretty prolonged courses of steroids, like 6 to 8 weeks. And we know that steroids are fraught with all sorts of side effects. And so what we actually did was we leveraged that international multi-center consortium data to look at patients who were treated with a longer duration of corticosteroids versus a shorter duration of corticosteroids. And in fact, we found that patients who were treated with a shorter duration had equivalent outcomes. So they had the same rates of recurrent ICI, AKI, or death compared to the patients that were treated with a longer duration. Now, of course, this is an observational study and susceptible to residual confounding, so we really do need those rigorous clinical trials. Now, there's a lot of interest now in studying other agents for ICI AKI, and in particular, infliximab, which is a TNF alpha blocker. And there's been a lot of work done by some of my collaborators at MD Anderson looking at infliximab for severe ICI nephritis. And this was a single center study of patients with biopsy proven ICI AAN. And they basically compared treatment with glucocorticoids plus infliximab to glucocorticoids alone. And they found that time to kidney recovery was actually faster in the infliximab treated patients. Now, again, this was a relatively small study and it's still subject to residual confounding as well as confounding by indication. So we are actually now embarking on a pilot clinical trial where we're testing infliximab versus standard of care 6 week of steroids to see whether infliximab has equivalent rates of kidney recovery, and therefore we can spare our patients some of these prolonged courses of steroids and all the associated side effects. This is a recent position statement that came out that I was a part of that is very helpful in kind of guiding the diagnosis and management of AKI in these patients and when to start and stop steroids. We also just recently published another set of guidelines in JASN that resulted from our ADKey meeting in Charlottesville 2 years ago. And so those are good resources for any of you who might be wondering how to manage and treat some of these patients. All right, so with that, I'm going to segue to a couple of questions. And so the first is, which of the following is not known to be a risk factor for ICI-AKI? The first is proton pump inhibitor use. The second is allopurinol use. The third is lower baseline estimated glomerular filtration rate. And the fourth is extrarenal immune-related adverse events. Okay. So the answer is actually allopurinol use. So interestingly, lower baseline EGFR was shown to be a risk factor in our study, but it's a little bit of a trick question because lower baseline EGFR, we also know that those patients are probably more susceptible to developing kidney injury, irrespective of whether it's interstitial nephritis or not. But interestingly, the other three were all found to be risk factors. However, allopurinol was not. The second question is, which of the following is the most common pathology on kidney biopsy in a patient with ICI-AKI? Is it acute tubular injury, IgA nephropathy, acute tubular interstitial nephritis, or thrombotic microangiopathy? Great. It looks like pretty much everybody got that answer. So it is, in fact, acute tubular interstitial nephritis. Okay, question number 3. So this is a 65-year-old patient with metastatic melanoma. He's being referred to you for evaluation of AKI. He's been treated with nivolumab for the past 4 months, no exposure to PPIs, no history of immune-related adverse events. His serum creatinine has risen from 1 to 1.5. He now has blood and protein on his urinalysis, and a 24-hour urine protein collection reveals 2.4 grams of proteinuria, of which 2 grams is albumin. His renal ultrasound shows normal-sized kidneys and no evidence of obstruction. On examination of his sediment, he does, in fact, have 10 to 12 non-dysmorphic RBCs per high-power field. So the next question is, what is your next step in the management of this patient? Would you go ahead and empirically treat with corticosteroids? Would you treat with rituximab, perform a kidney biopsy, continue the immunotherapy since the AKI is not that bad, or check a urinary CXL9? Okay, so it looks like pretty much everybody agrees that you would perform a kidney biopsy. Now, for A would have been correct if we had a higher suspicion for interstitial nephritis. But here, this patient had very atypical features. They had hematuria, proteinuria. And so for those reasons, you would really want to know exactly what's going on and could this patient have a glomerulonephritis? So even though 80% of patients on kidney biopsy might have interstitial nephritis, that means up to 20% of patients might have other lesions, and that includes tubular injury. It also includes glomerulonephritis like C3GN. We've seen IgA nephropathy and more. And so this would be a patient where you'd want to perform a kidney biopsy. So with that, I want to say thank you very much to, especially to Dr. David Leaf, who's the co-PI of the ICI-AKI Consortium, all of our collaborators at all of our sites around the world who have contributed to this effort, my lab and the other founding members of the American Society of Onconephrology, and my husband and 2 daughters, including my oldest, who actually wants to be a kidney doctor. And these are some references that might be helpful, and happy to take questions as well.